sphere may lead to environmental sustainability, and in the political sphere, it may lead to greater investments in development cooperation. Ultimately, these powerful synergies leads to reduction of poverty. The current target of the MDGs Goal 3 is to eliminate gender disparity in primary and secondary education, preferably by 2005, and in all levels of education no later than 2015. The chart above is about gender parity index for gross enrollment ratios in primary in developing regions 1990 and 2010. Especially in 1990, Southern Asia's enrollment ratio was 83%. However, in 2010, which is after 10 years of the enforcement of the MDGs, it increased up to 98%. Also, in developing regions as a whole, it increased from 91% to 97%, showing that the girls' enrollment ratio in primary education has achieved in many countries, which is the target number 97 to 103%. Then, accordingly, the importance of focusing on primary education for gender equality has been decreased. Then, what about secondary education? In this research, we examined the importance of secondary education through empirical analysis, and then we provide policy implications.
Now, I'll introduce our research design and analysis. We use two kinds of data, which are girls' education-related indicator and gender-related indicator. Girls' education-related indicator is collected from the UN site for MDG indicators, which is compiled by the Interagency and Expert Group on MDG indicators, which is IAEG. And gender-related indicator is collected by Human Development Report, which is presented by the United Nations Development Program, that is UNDP. We considered all developing countries included in MDG Report 2012, that is 169 countries, in year 2010, when MDGs began, and 2000 is MDGs began, and 2010, the most recent data available. However, due to the data availability, around 30 countries were analyzed among 169 countries. The focal variables are GPI and GEI. GPI is the Gender Parity Index, which measures girls' school enrollment ratio in relation to boys' enrollment ratio in education, girls per 100 boys. Especially, GPI 1 is the Gender Parity Index in primary education, and GPI 2 in secondary education. And GEI is the Gender Equality Index, which is newly made and used in this research, composed of labor market, empowerment, and reproductive health. GEI equals 1 minus GII, in which GII is measured by the UNDP, that is, Gender Inequality Index. Specifically, GEI is closer to 1. That means higher gender equality is achieved. We did the correlation analysis using SPSS, and the statistical significance is examined at 95% reliability level. First, we did the correlation between GPI 1, that is GPI in primary education, and GEI. And we did the same analysis between GPI 2, that is GPI in secondary education, and GEI. We compared the changes between year 2000, when MDGs began, and 2010, the most recent data available. This chart shows the result of the correlation analysis. The association between GPI in primary education and GEI was around 0.6 in 2000. But in 2010, the association became much lower, showing a sharp decrease to 0.345. In contrast, the association between GPI in secondary education and GEI was 0.588 in 2000, and also it was still high in 2010, which the association around 0.5, showing not much difference. So, if you see the significance level, GPI in primary education and GEI was significant in 2000. However, 2010 was insignificant. In contrast, we also noted that the association between GPI in secondary education and GEI was significant in 2000 and also significant in 2010. So, you can see the magnitude. GPI in secondary education is much bigger than GPI in primary education. Therefore, these patterns are consistent with our hypothesis that is, GPI in secondary education is relevant to gender equality. Therefore, our research concludes that investing more on secondary education than primary education to gender equality is necessary. Also, secondary education is more important driver than other factors such as tertiary education, market economy, and empowerment. This chart shows the correlation coefficient between gender equality and various factors, showing secondary education is much more important driver than other factors. In addition, however, strong primary education does not necessarily lead to strong secondary education. If you see the chart, several countries have achieved adequate level of girls' primary education, but they have a low girls' secondary education. This means that these countries did not have to achieving secondary education, although they have an adequate girls' primary education enrollment. Also, in the case of Korea, mandatory elementary education was enforced in 1950, while mandatory secondary education was enforced in 1985. That means time lag that is 35 years can exist when focusing shifts from primary education to secondary education. Therefore, special attention on secondary education is necessary and required.
Last is policy recommendations and future research. Indicator survey is the essential step of policy planning. However, in many countries, it is not available. The chart above shows that about 53% of the all developing countries are measured in secondary education. Secondly, about 32% of the all developing countries are measured in all levels of education. And only 10 countries among 169 countries have the data of all Goal 3 indicators, which contains education, market economy, and empowerment, which is only accounting for 6%. Therefore, indicator measurements must be expanded.
Sorry. Also, currently there are 5 indicators in Goal 3, gender equality, such as primary, secondary, tertiary education, market economy, and empowerment. However, other aspects which current indicators do not cover should be considered, such as girls' school completion rate and girls' learning outcomes in education sectors. In addition, the fact that important changes can happen over time should be considered, such as importance of secondary education that this research confirmed. Therefore, continuous update of Goal 3 indicator would be necessary.
We also suggest to UN member states to be more gender-oriented and to focus on mutual cooperation to achieving the Goal 3 of the MDGs among all developing countries, and in particular. The chart shows the countries that primary education has been achieved, but secondary has not, which is Burundi, the Democratic Republic of Congo, Mali, and Yemen. These countries also show low gender equality, lower gender equality index, lower than the world average. Therefore, further investments are required.
Finally, it is strongly recommended to allocate more resources for gender equality, especially female education. For example, look at the Korea ODA data. If you see the chart, expenditures used for gender equality in ODA in 2011 account for 16%. However, among those expenditures, those used in female education accounted for only 10%. Therefore, ODA in female education should be increased, especially secondary education. Also, we hope that this suggestion could be considered not only in Korea, but also in other UN member states.
We acknowledge that our research can have many limitations. Nevertheless, we hope that our research triggers future researches and further discussions about gender equality.
In addition, we hope all of these efforts could contribute to increase the quality of women's life, a better life. Thank you for listening to our presentation. Thank you.
Well, now we are going to hear judges' comment on the paper. I assume 2 judges will make comment.
Yes, thank you very much for the opening presentation. I think you did an excellent performance. It's always very difficult to speak first in an event like this, so I offer my congratulations. I was also very impressed by the clear and very logical approach that you set out. I thought the methodology, the explanation of your framework of analysis was very effective, and that you successfully visualized and represented all of the information and the data well. So I think that the main emphasis that you had on explaining how changes have occurred, that there has been positives in terms of the improvement of primary education, but still a lot of ways to go for secondary education was made very effectively. I like the fact that you tried to both describe and explain, and also towards the end offer some policies for improvement. However, I think one area that you could have looked at a little bit more is maybe the relationship between the factors, the organizations and structures that one would need to improve to achieve the goals that you want. I'm thinking about, for example, you mentioned, say, in the case of Korea, transitions of government policy to make mandatory education. I think it could have been useful to look at the way that particular nation states, the legal framework, the educational system operates, what ways that international organizations, the United Nations, maybe regional bodies and others could support. So what might be the relationship between forms of governance and so forth, and national, regional, international levels. I think one of the things that was also interesting that you highlighted was, although you showed great information about education and especially secondary information and made a convincing case, overall in terms of the range of indicators, as you said, there's a lack of data for us really to understand exactly what the relationship is between educational factors and maybe other factors. So, for example, why are women not in school? Is this something that can be resolved simply by legislation? Is it to do with various demographic, cultural and social factors, for example, age of marriage of women and so forth? So I think that overall this was a tremendously impressive performance, but I think that maybe some greater specificity and illustration of how we can understand and apply policies effectively would have helped you.
I appreciated very much the topic. Kemal Ataturk said at the beginning of the modern state of Turkey that Turkey could not become a developed country when only half of its population was paid attention to, and that's certainly the case in many places of the world. Your presentation was well-spoken, well-paced. I appreciated that. I liked the statistics that you gave and the strong methodologies employed. I also appreciated the recognition for the limits of the data that you provided, that it's not as easily accomplished. And then the thing I would suggest is you might recognize that the gender differentiation does not occur very readily in earlier educational areas. That might be one reason why you don't find a huge emphasis in gender parity at the lower levels. It's just not a relevant factor for young children. And then the last thing I'd suggest is look at cultural development, the cultural turn here. In terms of gender equality, there are different ways in which that's envisioned, and that's partly why I started off with recalling the comments of Ataturk. There are profound cultural differences which are going to get in the way of or maybe not just get in the way of, but complement a variety of approaches that might be taken towards gender equality. Thank you.
I'm Peter Beck from the Asia Foundation. I'm the other twin tower among the judges. I have 3 questions for you. Yeah. My first question is, can you explain the fall in the impact of primary education in terms of improving gender equality? In other words, why is secondary education so important? I mean, primary education intuitively should be very important because it really means the difference between literacy and illiteracy. So why is it that secondary education has so much impact on gender equality? Second, as students of Korea's top women's university, would you, since we have representatives from 20 different countries, would you say Korea is a model for improving gender equality, or does Korea still have a long ways to go? And finally, what can the UN really do to promote gender equality concretely?
Sorry for interrupt, but since we have such a tight schedule, we just allow all the judges can speak 3 minutes each. I'm sorry, you might answer the question during the lunch time, the judges. Right. Thank you very much.
Thank you.
All right, second team, Kim Joo-hye and others from Handong Global University in Korea will make presentation. The title of the paper is Policy Suggestion of HIV/AIDS prevention for health and poverty problems in developing countries.
Ladies and gentlemen, good morning. Good morning, everyone. My name is Juya Kim, and this is Hwan Song and Jinyoung Kim. We are from Handong Global University. We are here this morning to talk to you about HIV/AIDS issues and to suggest our policy for post-Millennium Development Goal. Before we start our presentation, we'd like to thank you for all the great opportunity that is given to us to share our policy suggestion. Today, our topic is practical program with infant circumcision and total health care service. This is for mother and child to improve HIV/AIDS and suggest public health part for post-MDG. Until now, Millennium Development Goal, MDG, have marked great achievement. However, when we examine the assessment of MDG deeply, we can easily figure out that the absolute poverty ratio hasn't decreased much to meet our expectation, especially in Africa. Among the 8 goals of MDG, public health regarding poverty is the primary issues in developing countries. According to recent research by WHO, health issues are vital to poor people to escape from poverty trap. Paradoxically, however, the matter of relating health to poverty problem is difficult and unsolved problem. Accordance with Goal 6, eradication HIV/AIDS, malaria, and other diseases in Africa is emerging as a significant topic. As you can see, the graph shows that international community has increased its financial aid for HIV/AIDS. Also, as you can see the map, the Sub-Saharan Africa indicate the highest HIV/AIDS prevalence rate among the globe. Also, people living with HIV/AIDS is occupied 70%, and the number of this is far greater than any other countries. The round graph on the right side indicates that Africa shows that number of deaths due to AIDS is really serious. Therefore, health intervention on HIV/AIDS is needed urgently. If you see the graph, you can see the people living with HIV/AIDS gradually increase till now. However, the number of people impacted annually has not decreased. The numbers are almost the same during 20 years. Therefore, more people living with HIV/AIDS, and due to the larger number of new impacts every year, for this reason, the prevention is really important. So, WHO and UNAI claim that among so many different types of methods of prevention, operation of male circumcision has been found to be most effectiveness in 2007. Until now, male circumcision program conducted in developing countries by lots of renowned, famous health organizations such as UNAI, Bill Gates Foundation, and Project Malai. Last year, I worked in a Project Malai. There, I managed male circumcision program for more than 1,000 people during 6 months. As a woman, organizing male student to male circumcision operation was really bit tough. But this task gave me a perspective on the reason why such a program is really important. This experience triggered me to solve this hard problem and build new HIV/AIDS prevention program policy after 2015. From now on, the detail of our suggestion presented by Jin-Hyung Kim.
Okay, hi, my name is Jin-Hyung Kim. And from now on, we focus on the primary issues of this presentation. Why circumcisions for HIV/AIDS prevention? Actually, it is unknown compared with other prevention programs. But in 2007, WHO and UNAI, they proposed circumcision as a solution to fight HIV/AIDS. And from 2005 to 2007, for 3 years, in South Africa, Kenya, and Uganda, they argued that circumcisions can reduce the HIV infection rate by about 60%. In many other studies, the effectiveness of circumcisions has been claimed. And how the circumcision could be prevented by how the HIV/AIDS could be prevented by the circumcisions. Simply speaking, through operations, the frenulum of glans penis is amputated and it leaves no glans penis. And the results on the right side picture, there are no chance for HIV intrusion. So, this process would contribute to the prevention of HIV/AIDS. And until now, in the most case, the target male is usually between the age of 18 and 24, but it has some problems. Adult circumcisions are more exposed to more risks and more likely to be complicated than younger men. Also, the gravity about healthy sexual relations is decreased, and they don't have any HIV/AIDS education at an earlier age. It requires to receive the financial support for proper education. Finally, they consumed more time and cost for operation. So, this paper focuses on overcoming the medical and social and economic limitations with the circumcision. And WHO and UNAI also claim that the early circumcision is beneficial to public health, and therefore, if the performing infant circumcisions, you can complement those limitations. And the most important thing is that circumcision on infant is effective in not complications, but the incidence rate of the HIV/AIDS. And these early preventions will provide the incentive to the people in the developing countries with a more effective education. And in addition, the operation cost is reduced to 1/4, and the cost savings may be used for the other health services. But unfortunately, there are also some problems with infant circumcision. Actually, on account of communication gap with the infant, the newborn babies may feel pain and cause complication. So some people said that circumcision is ethically inappropriate. So to complement this problem, after introducing the infant circumcision, the need for the prevention of HIV/AIDS should be educated and be inquired whether to perform the operation. Therefore, with the limitation, the proper public health policy and practical programs are needed. And WHO also argued the need for proper surgical and hospital services with the appropriate policy. If the effective practical programs will be configured as a systemic and comprehensive policies can be created. And now, we also propose the appropriate programs through the direction of the first MDG. Look at the middle sections. With birth, the hospital explained the need of circumcisions with the information including the effect and side effect of those services. And then they should ask whether to perform the operations with the parent. In this process, the education about HIV/AIDS prevention should be made on the basis of the national standard manuals. And overall, in this program, the mother and infant condition is checked, and vaccine and other medical services should be provided for infant. And after surgery, how to care the newborn babies with circumcision and how to educate HIV/AIDS preventions in their growth period. That it should be available with this program. And last, with the effectiveness of infant circumcisions, these practical programs can emphasize the advantage and minimize the limitations of already existing healthcare services. Due to the integration of services and practical program, they can maximize the cost effectiveness. And then these programs also directly or indirectly affect to the MDG goal 4 and 5 and 6. Now next presenters focus on how these programs can influence the MDG health parts. Thank you.
From now on, I want to explain how our practical program is related to Goal 4, 5, and 6 of MDG Health Field. We conceived the key action plan of healthcare system with infant circumcision. Our plan includes the effects on preventing HIV and AIDS, promoting the maternal health, and decreasing infant mortality rate. At first, practical program provides those services for Goal 6. We classify all the services according to the phase of childbirth. Before birth, we expand the antiretroviral treatment. Then, educate the parents about the necessity and the importance of circumcision to get their agreement. At birth, offer the infant circumcision program. After the circumcision, educate the parents about the HIV and AIDS education and give the infant sanitary supervising. For next, this is the process of the expected effects to decrease the children mortality rate. As I already explained the seasonal services, we also use the same service structure in this part. Before birth, educate the maternity about the childhood education. At birth, give the infants vaccination, and after birth, give more essential vaccination to infants like measles. All the services are really important to decrease the infant mortality rate, which affects to children mortality rate. We lastly expect to promote the maternal health. Before birth, expand the accessibility to hospital for maternity. In this way, the hospital can provide well-regulated care and support nutritional supplements to maternity. At birth, the hospital should encourage the birth in facilities and give the maternity management service. And this service can be extended to providing a postnatal care. Actually, the programs for achieving Goal 4 and 5 are not directly related to infant circumcision
and HIV prevention. However, those must be provided as a package because the practical program can maximize the efficiency of HIV and AIDS prevention with the healthcare system for maternity and infants. With the process in previous slide, mother, infant, and the family can get those benefits. Mothers can reduce harm infants through increasing infants' nurture training. And the infants can prevent HIV and AIDS early with circumcision and education. Also, the infant has the merit of receiving medical services. Plus, the family can get the education for HIV and AIDS prevention. And now, it is necessary to understand the relationship among the main agents and the role of the agents to provide the program effectively. Firstly, the hospital should develop the systematic service and reinforce the education for the local people. Secondly, the local administration needs to promote community interest and plan the fundraising for practical program. And lastly, government should make the policy for promoting circumcision in the context of the country and support to establish infrastructure for the healthcare system. Currently, various organizations are participating in developing countries to fight HIV and AIDS, and the suggested solutions are ideal and very macro. However, details and practical solutions are really needed. Even though the infant circumcision is a micro strategy, it is very important and significant in terms of a new approach for efficiency and effectiveness to fight HIV and AIDS. Our program will bring a great effect on preventing HIV and AIDS, and we want people to realize that the people having HIV and AIDS in developing countries must not be experimented but protected. Because we have the responsibility and the sense of duty in helping to sustain the value of their life. And we believe that the small changes can have big effects, and the small changes can be our practical program. And thanks for listening, and please feel free to comment on our presentation.
All right, thank you. Now we are going to hear judges' comment.
Thank you. Thank you for the opportunity to comment. I think you've made a very good presentation highlighting health issues and their relevance in the MDGs. That's well argued, well presented and argued, and very relevant to the achievement of the MDGs. The correlation between HIV prevalence and poverty was well presented in the world map, and that showed that in the countries that are mostly affected by poverty are also now, unfortunately, mostly affected by the HIV. The importance of prevention, the focus of circumcision without reference, sufficient reference, I think, to the other prevention recommendations like education, awareness raising, use of protection, which is condoms and other kinds, I think could have strengthened your argument. Because while, of course, I am aware of the research on the role of circumcision in reducing infection, that only actually protects the male partner, when in fact it does nothing to affect the affection by the female, and you didn't touch on that, which is the majority of infections now are actually male to female in Africa. So that is a small weak element in your presentation that could have been more addressed in terms of strengthening the reference to that issue. The other thing is circumcision is important. However, is also important is the need to deal with the issues of stigma, discrimination, and marginalization, which is the topic of this presentation, of people affected with HIV. And before, marginalization and the stigma are actually big factors of increased infection with HIV, because those who are affected are afraid to come out, and therefore nobody knows that they are affected. They don't go and get the treatment, and they infect others, and that creates the vicious cycle. Overall, you've chosen a very difficult topic, but I think you've had a very good presentation. Thank you.
I think you learned a lot about the Millennium Development Goal by doing this project, especially about the 8 goals. What I would like to suggest or make comments on is about widening the scope of discussion, including human rights. What is human rights? There are female circumcision practice in 28 countries in Africa and Middle East. And it is determined, it is identified as a violence by the UN. How about male circumcision? Do we know enough about the psychology of the infant with or without circumcision? We don't know enough knowledge. So we need more in-depth studies on the psychological effect or that may have cumulative impact on his life in his later life, especially during his adolescent period. Males can, with circumcision and without circumcision, have different opportunities to deal with sexual desire, things like that. So that is one comment. Another one is, this problem is quite peculiar to the southern part of the Africa, where the rate of infection is more than 10%. Some countries, like almost 30%, but less relevant to countries like East Asia, where there is much less than 1% of the population is infected. So that is implies that a general application of this policy implication may not be so balanced. Another, lastly, the government level intervention or the individual family level intervention, we need to think about which one will be better. Thank you.
Thank you, judges. Thank you. Please join them. A big hand. Third team, David Alenga from Ghana, will make presentation. The title of the paper is Disability and Poverty in the Post-2015 Development Agenda. Please welcome him with a big applause.
Good morning, ladies and gentlemen. As rightly introduced, my name is David, here with my team partner Jenny, who doubles as my sister as well. And nothing comes close to an irony to get to realize that the son of a medical officer becomes disabled from a disease such as poliomyelitis that is not only preventable, but for the most part has been eradicated in most parts of the world. That is the beginning of my extraordinary story and challenge growing up as a disabled boy in an environment that is basically completely alien. I grew up in a middle-income family, in a middle-income neighborhood, where almost everything was all right. I never realized I was disabled because everybody understood and related with me in the right way. Time came, I had to go to school. I went to school in an extraordinary way, not very similar to what most people have experienced. I got a personal attendant, a caregiver, who had to take me to school every day for 9 years. Not only that, she had to sit with me in class and ensured that during lunchtime, she provided for me, basically attending to my needs all the way through in class. It was extraordinary. I really hated that.